Welcome to the next video on second-line therapy. In the recent set of videos, we've been discussing treatment for the stage 4 or unresectable disease, which is also referred to as palliative therapy. We went through a number of different videos for first-line therapy, looking at the backbone chemotherapy, whether it be FOLFOX or other, and specific biomarker-directed therapy for HER2 positive, PD-L1 positive, Claudin positive, or all negative. We also talked about maintenance and monitoring how successful this therapy is in the most recent video. Now we're going to be focusing on second-line therapy, and in particular, the so-called rainbow regimen, or paclitaxel and ramucirumab, and how that was derived. As a quick summary for what to expect with first-line chemotherapy, remember, FOLFOX chemotherapy with 5-FU, folinic acid, and oxaliplatin is preferred, but there are other options that one could use. In terms of benchmarks of outcomes, what one might expect, almost half of patients will have a response on the scan, so more than 30% shrinkage from what it started as. A large proportion will have disease control, and so that isn't a full shrinkage, it's stable disease as your best response, but at least it's not growing. And then we talked about how long it typically works for on average, from 6 to 7 months. And in terms of survival, about a year, given more recent studies showing, especially with the introduction of later line therapies, which we're going to talk about today. And then, of course, when you do fall into one of these biomarker groups, adding the specific targeted therapy to them, backbone chemo, can improve on each of these parameters. However, eventually, as we talked about, whether you're doing maintenance therapy or not, eventually we will experience resistance to the treatment, where the cancer basically learns how to grow on that treatment, and we would need to change. So remember this figure where we're trying to keep in balance the control of the cancer, but also limiting side effects. And so in the setting of where it's working well, we can afford to take treatment breaks, holidays, or go down to maintenance, dropping off the other chemotherapy, whatever is being added to 5-FU, usually oxaliplatin. So eventually, though, we will experience when this cancer is resistant to the treatment is no longer working. And so really, the idea is that we would treat with the first-line therapy until there's evidence that the cancer is growing on that full chemotherapy, or there's intolerance to the regimen, no matter what that is. Usually the most common thing is oxaliplatin neuropathy, requiring us to change to the next line of therapy. For whatever the reason, we do have to consider moving to second line therapy at some point in most patients. So here's a summary of all the reasons one would change to the next line of therapy. We talked about an obvious progression on scans or clinically or both, to the full chemotherapy, and with the biologic targeted therapy if appropriate. Or if there's obvious progression on the maintenance component of the therapy, and it's felt that resuming, in this case, the oxaliplatin, is not a good idea because there's side effects from it. Typically, again, it's neuropathy, but it could be anything. We talked about less common things like an oxaliplatin allergy. And so even if you have progression on maintenance therapy, and normally we would be considering resuming the oxaliplatin, if we can't, that would be grounds to change to the next line of therapy. And then lastly, we talked about even if there's not obvious cancer progression on the scans or in the blood markers, if there's concern that there's clinical progression, this happens not infrequently with peritoneal-only disease and other cases where it's not obvious on scans, but there's a sense that there's progression of the cancer. That would be grounds to switch to the next line of therapy. When we talk about second line therapy, the goals of that therapy are the same as in first line. So when you think about the balance where we're trying to control the cancer and limit side effects, that applies to second line therapy as well. And similar to first line therapy, the main goals are to, of course, try and control the cancer, as long as possible while limiting side effects as best as possible and to optimize our quality of life. Similar to the first line setting, even if it's working in second line to attain those goals, eventually we will expect and experience resistance of the cancer to that next line of therapy. In terms of benchmarks of what to expect, we're going to go through the actual evidence from studies, but this is a summary of what one might expect with a second line therapy in terms of response rates. You'll see that the optimal regimen of chemotherapy plus a targeted agent called ramucirumab achieves a response rate of around 30% of patients will have shrinkage. Another proportion will have disease control. And the median progression-free survival, the time that it works for on average is around 4 or 5 months. And overall survival from the time of starting second line therapy ranges depending on the study, but from 7 to up to 10 months. So when we go back to the principles of chemotherapy video, we talked about all the different kinds of chemotherapy. In the first line setting, we focused on 5-FU, which is a pyrimidine antagonist, and platinum agent, oxaliplatin. Now in the second line setting, we're going to be talking about irinotecan and taxanes. So topoisomerase inhibitor 1, like irinotecan, and mitotic spindle inhibitors like taxanes. And we also talked about how combining agents is synergistic and enhances the effect and delays the onset of resistance. And so we'll talk about combinations like 5-FU plus irinotecan, or the regimen called FOLFIRI. So what is the evidence to use chemotherapy in the second line setting? Well, we go back, you can see the publication dates here are about 10 years ago, and even longer than that. In routine practice, we would use these so-called salvage chemotherapies. After the first line stops working, can we switch to another type of chemotherapy, and will that be more effective than just best supportive care, or also known as active symptom control? And so in these two different randomized studies, you can see they're not huge studies in terms of the numbers of patients enrolled, but these are randomized controlled studies. On the left, you see a study that was done in Asia that randomized patients to salvage chemotherapy or best supportive care. And if you were randomized to the salvage chemotherapy arm, physicians had the choice of using either irinotecan or paclitaxel. And about half the patients got irinotecan and half paclitaxel. And you can see that the patients who got one of those in the blue curve did better in terms of overall survival compared to those who got best supportive care without any active systemic therapy. And on the right side, we saw the same sort of study design of randomizing to chemotherapy. In this case, everyone got docetaxel, another type of taxane, or active symptom control, best supportive care. And again, this study showed similar survival advantage if you were to continue on chemotherapy. In terms of response rates, what one might expect with a monotherapy chemotherapy agent like these would range, but we usually quote around 10 to 15%. Another 45% or so of patients won't have shrinkage, but will at least have stability of their cancer. It won't be growing. And overall, when you add those together, those responding and those stable, the disease control rate is around 55% of patients. So you can see that these numbers are a little bit lower than first line chemotherapy in terms of what one would expect. And so that's a general principle that after the cancer learns how to grow on the first regimen, moving to the next line, one expects a little bit less likelihood that this would be effective. That's not to say that it wouldn't be effective. You can see that there's a large proportion here that will at least have disease control. So it's better than the alternative, which is best supportive care. But just have to recognize that the response rates are lower. Where first line therapy, it's around 40 to 50% of patients will experience shrinkage. Here we're talking about 10 to 15%. So those types of studies really solidified what many of us were already doing and even predated those publications. And so those randomized studies led to the inclusion in NCCN guidelines. We've talked about the NCCN guidelines as a sort of cookbook of all the different options one might use in various situations. In this case, we're talking about second line or subsequent therapy. And again, we've always qualified that we would have to have a maintained performance status, strength, and ability to continue on therapy. And also, because there's a lot of options, it would depend on what you actually use on what was used most previously. And so, again, generally, most patients are getting FOLFOX chemotherapy in the first line. So that study, the Cougar-2 study with docetaxel versus best supportive care, and the Korean study of choosing either paclitaxel or irinotecan led to the inclusion of these agents in the option list of preferred regimens for second line. Remember, category 1 means that they have robust clinical trial evidence, and we do have that based on the previous slide showing randomized clinical trials. So what else do we have? We also have a targeted therapy called ramucirumab. And remember, in the principles of targeted therapy video, we talked about this pathway of angiogenesis, where a number of different growth factors or ligands floating around in the bloodstream can bind to receptors on cells in our body. And those receptors are called vascular endothelial growth factor receptors. And there's different versions of that, type 1, type 2, type 3. It turns out that there's a number of different ways to inhibit this pathway, from antibodies that bind to and neutralize the ligands, or antibodies like ramucirumab that bind directly to the receptor. So ramucirumab binds to VEGF receptor 2. And there are also tyrosine kinase inhibitors that are usually oral agents that go into the cell and inhibit the receptors on the inside. So in second line gastroesophageal cancer, the studies that we're going to focus on are with ramucirumab that are binding directly, inhibiting this receptor. In later line therapy, we're going to be talking about regorafenib, which again is a tyrosine kinase inhibitor and binds on the inside of these receptors. And just as a quick refresher, remember this pathway, when active, leads to blood vessel formation. And so cancer cells use this pathway to help recruit blood vessels as the cancer mass is growing, and also so they can get into those blood vessels and start to spread outside. So the idea here was, can we inhibit with anti-angiogenesis agents, in this case ramucirumab, and have benefit in controlling the cancer? So the first main study that was conducted was a large randomized phase 3 study called the REGARD study. And you can see the date that it was published was around the time that those other phase 3 studies were being reported of chemotherapy versus best supportive care. So there was no defined second line therapy at the time of designing this study. And so it was reasonable to assess whether ramucirumab as a monotherapy by itself compared to a placebo, basically just best supportive care, would be better than just the placebo. And so on the left, you see the overall survival curve, and on the right, you see the progression-free survival curve. And you can see in red, ramucirumab performed better than just the placebo. And so this led to a recognition that ramucirumab could be used as a monotherapy. Now, I'll point out here in this table of ramucirumab versus placebo, you can see that for every 3 patients, 2 patients received ramucirumab and 1 patient received placebo. So this is called a randomized control study that is randomized in a ratio of 2 to 1, 2 getting ramucirumab versus 1 getting placebo. And so that's done to sort of optimize accrual, to enhance the chances of any given patient to actually get the study agent. And so the first thing I'll show then is that the response rates were not much different with ramucirumab versus the control. It was about 3%. However, the disease stability, those who had stable disease not growing, was more than twice. And so this translated to a disease control rate, when you add those responding and those having disease control, that was better with the ramucirumab versus the placebo arm. So this led to, again, recognition that this could be an option. But the real question was, can we add agents like ramucirumab to backbone chemotherapy, which already showed benefit compared to just best supportive care. And so this is really the pivotal study that everyone sort of quotes, the Rainbow study. And it was a randomized phase 3 study that was randomizing patients to either paclitaxel and ramucirumab or placebo and paclitaxel. So everyone was getting paclitaxel, and then half the patients were getting ramucirumab and half were getting placebo. And again, you see here on the left side the overall survival and the right side progression-free survival. And again, the ramucirumab arm performs better. That's the red curve. And in terms of response rates now, you can see that those that got ramucirumab had an improved response rate. So about 27% of patients had response with ramucirumab and paclitaxel versus around 16% who just had paclitaxel with the placebo. And similarly, the disease control and stability was a little bit higher. And so overall, the disease control rate was better in the ramucirumab and paclitaxel arm. And so this regimen is often referred to as PAC-RAM, you may have heard of. And so this was a pivotal study that then led to chemotherapy with ramucirumab being a standard second-line option. So a very important question that was asked at the time was, does this result translate to patients who are HER2 positive? And so at the time, remember, the standard first-line regimen for HER2 positive cancers was the TOGA regimen, which was chemotherapy with a 5-FU and platinum with trastuzumab. And so in the Rainbow study, about 6% of patients had received prior trastuzumab therapy. So implicitly, they had HER2 positive cancer. And so in that subgroup analysis, you can see it's a smaller subset of the patients, about 6%. The question was, do these patients derive benefit from the ramucirumab in addition to paclitaxel versus paclitaxel alone? And you can see the red curve represents those patients who got the ramucirumab. And so for overall survival on the left and progression-free survival on the right, this was the case, and those benefits were seen in HER2 positive group as well. So the results could be applied to not only HER2 negative patients, but also HER2 positive patients who had failed the first line therapy. TOGA regimen had stopped working. Okay, so this was a regimen that then became implemented. You can see that their response rates were actually even better than the HER2 negative group. They were 45% in the ramucirumab arm, and the disease control rate was about similar to what was seen in the overall group, which was, remember, 79%. So 80% of patients obtaining disease control. So that's summarized here, the Rainbow and the Regard studies. And you can see the size of the studies, the numbers of patients enrolled, the treatments they were getting. The primary endpoint was overall survival. You can see the incremental improvements that ramucirumab adds. It adds around 2 months of overall survival. It adds about a month and a half of progression-free survival. And it improved the response rates, at least when combining ramucirumab with chemotherapy. So the pivotal study here is the Rainbow study, which is the preferred regimen then in second line, irrespective of HER2 status. And so the NCCN guidelines appropriately then added this ramucirumab and paclitaxel Rainbow study to a preferred regimen for second line. And you can see here that ramucirumab alone is also listed based on the Regard study, not preferred. The outcomes aren't as good, but if for whatever reason, for example, a patient can't get chemotherapy, one might still consider using ramucirumab alone. Now, the next series of slides are looking at what else could be used with ramucirumab besides paclitaxel. I showed you studies that confirm that irinotecan compared to best supportive care would be useful in the second line. And although there haven't been any large phase 3 studies yet looking at irinotecan-based regimens plus ramucirumab, I'm going to show you some studies that support its use here. So this was a retrospective analysis of a number of investigators, including myself, that looked at patients that they treated with FOLFIRI and ramucirumab in the second line and pooled their outcomes and looked at what the results were. And so first, let's just ask, why would we want to use a irinotecan-based regimen compared to taxane, like paclitaxel? And so the first variable here is, did the patient already get a taxane? For example, some patients get FLOT chemotherapy, which we've all heard of, and we will talk about when we get to perioperative videos at the time of around surgery with curative intent. And so patients get FLOT chemotherapy, which includes taxane, docetaxel, or taxotere, which is the T in the FLOT regimen. And they'll get that for 4 cycles before and 4 cycles after surgery. Sometimes patients, unfortunately, will still have cancer recurrence, sometimes quickly, right after completing the FLOT. And so going on FLOT and then changing to second-line chemotherapy with a taxane like paclitaxel is sort of counterintuitive, counterproductive, where your cancer's already shown growth on docetaxel. It doesn't make as much sense to use paclitaxel. One might want to try a completely different class of chemotherapy like irinotecan. And so a little bit more about that. Generally speaking, if a patient completes their FLOT chemotherapy perioperatively and then has a cancer recurrence within 6 months or even 12 months, that might be considered a quick recurrence. And so rather than resuming first-line therapy with FOLFOX, which is in the FLOT regimen, one would consider changing to second-line therapy at that time point. And so, again, in that situation, you've just had 5-FU oxaliplatin and docetaxel. Is there a better regimen than paclitaxel and ramucirumab to use? Secondly, in patients that got first-line FOLFOX or perioperative FLOT, they often have an element of residual oxaliplatin neuropathy. And taxanes, as you remember, can also cause neuropathy. So is there a regimen that is not as toxic to the nerves, like paclitaxel, that we could use? Remember, irinotecan does not cause neuropathy. And so, again, that's another reason why one might consider changing to second-line irinotecan-based regimen as opposed to paclitaxel. And then lastly, just for convenience, the irinotecan FOLFIRI regimen is given very similar to the FOLFOX regimen every 2 weeks. So this is our nomenclature for that, every other week, or QOW, versus paclitaxel, which is given weekly. And so just for convenience and ease of administering, you can come to the office every 2 weeks instead of weekly. And so that's an advantage. So the other thing to point out is that in this analysis, the patients were getting a modified FOLFIRI, so they weren't getting a 5-FU leucovorin bolus. And so that should be recognized that FOLFIRI given with the full regimen with the 5-FU bolus has a little bit more side effect profile. And you may recall from previous videos that it's my preference to not include the bolus, whether it's in FOLFIRI or FOLFOX. But certainly if one starts with that, then that would be the first thing to stop if you run into trouble with side effects. So what did we see? Across the institutions that were involved in this study, we gathered around 30 patients who received this regimen in second line. And you can see the response rate, the disease control rate, the median progression-free survival, and then the patients alive at 6 months and at 12 months were very similar to what one would expect with the paclitaxel and ramucirumab regimen from the Rainbow study. So not a randomized study, but a suggestive result here that this could be interchangeable. It's not necessarily better than paclitaxel and ramucirumab, but it provides an alternative option, especially in these particular situations. If you've already had a taxane, or if you have residual oxaliplatin neuropathy that you want to try and avoid with more taxane, FOLFIRI could be an alternative second-line regimen. And then in the interim, a randomized study called the RAMIRIS study, it was a phase 2 / phase 3 study. And so that means that it's enrolling a phase 2 sized study. Remember, go back to the video on principles of clinical trials, the difference between a phase 2 and a phase 3. But sometimes studies are designed to be a combined phase 2 and phase 3 study. And so after the patients are enrolled for the phase 2 part of the study, then results will be reported. And if they're promising, then it would seamlessly move on to the phase 3. And so this RAMIRIS study was reporting a few years ago at a meeting and published last year of the phase 2 part of the phase 2/3 study. And what this study was assessing was patients that had finished first-line therapy, it had stopped working or was no longer tolerable, and then were ready to start second-line therapy. And they were randomized to either paclitaxel and ramucirumab or FOLFIRI and ramucirumab. So the rainbow regimen versus FOLFIRI and ramucirumab. And what you see here is that there's no real statistically significant difference. If anything, the FOLFIRI arm in darker black is a little bit better than paclitaxel, but it wasn't expected really to be better. It just provides another option. And as you can see here, you're not losing by using FOLFIRI instead of paclitaxel. When you look at the breakdown of patients on the top row who did have a prior taxane therapy, usually as part of FLOT, usually perioperatively, but even in the first line setting, some patients get FLOT, compared to those patients who were getting second line therapy who had never had prior taxane. And you can see that overall in this latter group, there's no real significant difference of FOLFIRI versus paclitaxel combined with ramucirumab. But in those who did have a prior docetaxel, using more paclitaxel in the next line really looked like it was a little bit worse than continuing with a different regimen with FOLFIRI. So the summary of this study to me as a second line phase 2 study is that FOLFIRI could be used in replacing paclitaxel, especially in patients who've had a prior taxane therapy like docetaxel. But even in those who haven't, one could consider it, say, for example, if you have residual oxaliplatin neuropathy from first-line therapy, and you want to avoid that, you could switch to FOLFIRI and not lose anything and still gain benefit from controlling the cancer. So based on those studies, you can see here that the NCCN guidelines includes irinotecan-based regimens, whether it's irinotecan alone or FOLFIRI with ramucirumab as an option in second line. So we talked about first-line maintenance therapy and the strategies and the reasoning why one might do that with FOLFOX to try and optimize the use of oxaliplatin over time and limit neuropathy with something that was called OptimOx strategy. The same could be applied to second-line therapy with either paclitaxel and ramucirumab or FOLFIRI and ramucirumab, and the same decision-making process that we went through in terms of trying to optimize the balance between cancer control and quality of life and limiting side effects. And so similar to with maintenance therapy with FOLFOX, one can drop in and out the irinotecan and paclitaxel and continue with the other agents for a maintenance phase, if appropriate, and usually after a good 4 to 6 months of the full regimen. If it seems to be working, the cancer is well controlled, then one can drop off the irinotecan or the paclitaxel and continue with the other agents, and only consider resuming them if and when there's progression on the maintenance regimen. And so in my experience, this also sort of increases the longevity of being able to use these regimens, particularly if you're using paclitaxel. The cumulative neuropathy from paclitaxel can be a nuisance. But similarly, even though irinotecan doesn't cause neuropathy at all, it also has cumulative side effects. Usually it's just fatigue. And so being on it for long periods of time, one can drop it off for a period of maintenance, and that usually goes a long way with recuperating and gaining some stamina back. Again, one could build in full chemo breaks in this setting if warranted, and if the initial treatments with the full chemotherapy did exceedingly well, then one might consider a full chemo holiday for 5 or 6 weeks just to get a break for the same reasons that we talked about in the first line setting. So maintenance and second line therapy could also be applied, as we talked about. This slide is just to address the question that patients have sometimes as well. If ramucirumab works in second line, why don't we just use it in first line, or especially in patients that are biomarker negative? They're HER2 negative, they're PD-L1 negative, they're claudin negative. They don't have a better target to go after. In other words, can we use ramucirumab plus, say, FOLFOX? Well, the summary table here shows a number of different studies that are listed here. They're all in first line, and all the red means that they were overall considered negative studies. The two boxes are the two large phase 3 studies. You can see the sizes are a lot larger than the other studies. The first one was the Avast study looking at a drug called bevacizumab, or Avastin, which is an antibody that binds to the VEGF ligand, or ramucirumab, the drug we've been talking about, that was compared to placebo in combination with chemo in the rainfall study. And you can see here the endpoints like median overall survival, the primary endpoints, were slightly better in both of those arms, but they weren't considered statistically significant. Similar with PFS and with response rates, they were all slightly a little bit better, but they weren't enough to be called positive studies. You will note that the size of these studies are a lot smaller compared to, say, some of the immune checkpoint inhibitor studies that we've been talking about. For example, Checkmate 649, which was pretty much 2 to 3 times larger in terms of the size of the patients. And remember, the larger the study, the better it is to detect small differences. And you can bet that if these studies were the size of, say, Checkmate 649, these smaller differences might be considered statistically significant, and these would be considered positive studies, and these would be agents readily available. But this was in an era where studies weren't done so large, and really the idea was we want to find a larger benefit for patients, and if it's just a small benefit, it may not justify the added toxicities and or the cost of the therapy. So suffice it to say, using anti-angiogenesis drugs like ramucirumab or others is not considered a standard. It has been investigated in a number of studies. There was a suggestion of some small benefit, but it wasn't enough to become a routine standard of care. So the last thing I'm going to point out in the second line video here is at the bottom in the NCCN guidelines. There's a lot of drugs listed for specific biomarkers in certain circumstances. And so the first one is for MSI-H tumors or mismatch repair tumors, which is about 3% of stage 4 gastroesophageal cancer, mostly in the stomach and maybe at the G junction, less so in the esophagus. And you should know that there are approvals for immunotherapy drugs like pembrolizumab, nivolumab, ipilimumab for these tumors if they've not received it yet in the first line. And so it's sort of a moot point because most patients are going to be getting this in the first line setting because most patients will fall in the PD-L1 positive category. And even if they're not PD-L1 positive but MSI high, they probably should be getting chemotherapy plus immunotherapy in the first line setting. So similarly with tumor mutation burden high, which is defined as 10 or up to 20 mutations per megabase, if you're looking at your Foundation 1 report or other gene sequencing reports, which is about 10% of patients that will fall into this category. Again, most of these patients should be getting this anyway in the first line setting because most of these are PD-L1 positive. But if you're not, then one might consider this. If you haven't already gotten a checkpoint inhibitor in first line, one might consider this in later lines from second line therapy or higher. The other last point I should make is that most MSI high tumors are TMB high, but not all TMB high tumors are MSI high. So the subset of TMB high that are MSI high should definitely be getting a checkpoint inhibitor in first line, and if they haven't, get it in later lines. And then if you're not MSI high, you're microsatellite stable, but you have a high tumor mutation, one could consider using an immunotherapy drug if you've not already had one in first line. And then the other 3 biomarker groups listed in here are NTRK fusion. This is an oncogene that has a fusion, and it happens very rarely in this disease. But if it did, this would be a good option for you to get a matched targeted therapy oral drug. I have yet to see this occur in gastroesophageal cancer in the last 10, 15 years, but it's possible. And similarly, BRAF mutation, which occurs in about 5% of gastroesophageal cancers, has a specific targeted regimen of 2 targeted therapies that are oral drugs in this specific indication. So again, something to be considered in later lines. And then lastly, we have RET fusion, another gene, oncogene that can be activated through fusion, a translocation. Again, it's not common. I've seen it once or twice, but again, these patients could be treated with targeted therapies that target that RET gene. And so the last thing I should point out is that these approvals are for any solid tumor type. It doesn't matter where it came from. And the studies assessed patients that had these genetic events, irrespective of where the cancer originated. So there were colon cancer patients, there were breast cancer patients, lung cancer, gastroesophageal cancer, etc. And they were pooled together. And they weren't randomized studies, they were smaller studies, but their outcomes were good enough that they were approved by the FDA for those indications. And so they're listed here as options in second line or higher. In terms of where you would use this, would you use it in second line, or would you use paclitaxel and ramucirumab or FOLFIRI and ramucirumab in second line and save these for later? That's a matter of debate, and I think should be applied to individual cases based on the features that are going on in that particular person's case. So lastly, we're going to be focusing on in the next video about anti-HER2 therapy in the second line and higher space with trastuzumab deruxtecan. And lastly, we'll be going on to the third line or setting or higher and looking at the TAG study, which looked at trifluridine tipiracil, also known as Lonsurf, in that third line setting or higher. So this table is for second line or higher in the NCCN guidelines. So in this video, we talked about and focused on second line therapy, specifically the paclitaxel and ramucirumab regimen, which now is certainly the standard of care for HER2 negative tumors, could also be used for HER2 positive tumors, as I showed you, but we will also be looking at other evidence that one could use in the second line setting. We talked about how FOLFIRI or irinotecan could be used in replace of paclitaxel and the reasons why one might consider doing that. And we also talked about a number of pan-solid tumor approvals for second line or higher, including immunotherapies in the setting of TMB high or MSI high. Again, should probably have already gotten it in the first line setting, but if they haven't for whatever reason, they should definitely get it later. And then we talked about other less common gene abnormalities that could be identified and their matched targeted therapy in the second line setting or higher. The last thing I'll say is that clinical trials are always encouraged. You saw the benchmark that one would compare to is really the Rainbow regimen, with the response rate around 30% and median overall survival just less than 10 months. And so any study that's being assessed in the second line setting for HER2 positive or HER2 negative really should be comparing to those benchmarks, and to change the standard of care, as you'll see when we go into the HER2 positive studies, they really need to be compared directly to this and show benefit. So again, in summary, we talked about second line therapy. We talked about the reasons for changing from first line to second line. We talked about what studies led to chemotherapy being used routinely. We talked about which studies led to ramucirumab being used routinely, particularly in combination with chemotherapy, whether it be paclitaxel like the Rainbow study, or irinotecan like the retrospective analysis and the RAMIRIS study. And we talked about also that HER2 positive disease really was included in those studies, and so those are options for patients with HER2 positive disease in the second line. And then lastly, we talked about a number of biomarker subgroups that have pan-solid tumor approvals in the United States only, that could be considered in second line or later line, and to consider those when appropriate. In the next video, we'll be looking at HER2 positive cancers in the second line therapy and evidence for that. So stay tuned. Thank you.